Good morning, good afternoon, good evening, everyone. Greetings from Global Alliance for Medical Physics Education and Research, GAMPER. I'm Abu Kausar, Director of GAMPER, and it is my great pleasure to welcome you all to today's insightful webinar on motion management in radiotherapy, a clinical and technical perspective. This event is organized by GAMPER in cooperation with BeamHub and made possible through the collaborative efforts of professionals across different regions, united by a shared vision to promote evidence-based radiotherapy practices, especially in diverse and resource-constrained settings. We're truly inspired by the tremendous global response to this event, with over 1,400 participants from the countries worldwide, representing Africa, Asia, Europe, North America, South America, and Oceania. I am also delighted to introduce our moderator for today's session, Dr. Rozilawati Ahmed, a respected academic and clinical expert with vast experience in image-guided and adaptive radiation therapy. Now, Dr. Rozilawati, the virtual floor is for yours.
All right. Thank you, Chairperson. I'm Rosie Ahmad. You can call me Rosie Ahmad. Probably my long name is very difficult to pronounce. You can always call me Rosie Ahmad. Good day, everyone. Morning, afternoon, evening, probably across the world. Welcome to this session, a special session of GAMPER Webinar Series. And we are delighted to have all the participants joining us, different parts of the world. I can see in the chat board, it's from Nigeria, then from Vietnam, Philippines, and of course from Malaysia. My country also are here. So again, just to introduce a little bit, introduce of myself. I'm the moderator today, and you can call me Rosie Ahmad. Thank you very much, and a very warm welcome to everyone. I'm honored to moderate this exciting session. So before we begin, let me give some. Let's do this a little bit interactive activities. All right, on your bottom part of your Zoom, you can see some react. You can give some reaction. Can I see that if you are undergraduates, postgraduate student, can you show some thumbs up? Maybe we can have some ideas. Are your students postgraduate, undergraduates? Any thumbs up? Can you see the react button down there? You can see the icons. Anyone would like to share some response? Or probably you are medical physicist. Show thumbs up. Anyone? Or you can write down in your chat box. Oh, okay, I can see many of you. Okay. How about anyone here, oncologists or clinicians? You have some radiotherapy students here. All right, good. So I can see that, okay, some radiation therapies, clinical oncology. So just to have some ideas to the panels that we have vast, diverse of participants here. So we can make it more general so that everyone can benefit from our talk today. All right, thank you for participating. Our little engagement here really helps our panelists actually to connect their insight with you. So let me now go through today's session. We will begin with keynote presentation from our invited speaker, and then followed by the panel discussion with distinguished expert we have from US, UK, and also Egypt. After that, we will open the floor for audience questions. So you can always type in the chat box. Someone will help me on tracking the questions later. And finally, we will conclude the closing reflection from our panelists. All right. Now we start with introduction of the panel and also speaker. It's a privilege for us today to be joined by the distinguished panel expert and our keynote speaker. First, we start with Prof. Dr. Parham Alaei. Dr. Parham, Prof, say hi.
Good morning, good afternoon, good evening to
Hello, hi. So Dr. Parham, Prof. Parham is a professor and also director of medical physics in University of Minnesota, where he also leads the graduate programs in medical physics. With more than 45 peer-reviewed publications, 6 books chapter, and over 70 international presentations, Prof. Alaei has made significant contribution to dosimetry, treatment planning, and also physics education. He also served as a program director for AAPM Summer School and also co-edited its proceedings. Next, we have Prof. Dr. Mostafa Shauki Elhaddad. Hi, Prof. So he is a Prof of Clinical Oncology at Cairo University, also practices as a consultant clinical oncologist in the UK, trained in Heidelberg, France, Switzerland, and the UK. Prof. Elhaddad has served at leading cancer centers such as Royal Marsden and Southampton University Hospital. With over 30 international publications and 15 years of teaching experience, he has greatly advanced oncology education and also practice in the Middle East. We are also joined by Dr. Mahmoud Yunis from UK. Hi, Dr. Yunis. Dr. Yunis is the lead physicist at Genesis Care London with more than 20 years of medical physics experience across the UK, Saudi Arabia, and also Egypt. He has overseen the commissioning of advanced radiotherapy system, and his expertise cross over MRT, VMAT, SRS, SBRT, and also adaptive radiotherapy. He has published and presented widely on MRT and VMAT, optimization and adaptive RT. And also he is a registered clinical scientist in the UK. And now our special keynote speaker, Dr. Kanhu Charan, Patro from India. Hi, Dr. Patro. He is a clinical director and head of the Department of Radiation Oncology at Mahatma Gandhi Cancer Hospital and Research Institute. 21 years of clinical experience. He specialized in MRT, VMAT, SBRT, SRS, brachytherapy, and total body irradiation, TBI. He has authored many publications, guided numerous postgraduate residents, and also founded Scope Group to promote knowledge sharing in oncology. Beyond the clinic, Dr. Patro leads cancer awareness campaign and translational research, making an impact both professional and also community levels. So ladies and gentlemen, please join me to welcome Dr. Kanhu Chandra Patro to deliver his keynote presentation. Dr. Patro, the floor is now.
Good evening. I am Dr. Charan Patro. I am a radiation clinical oncologist from India, Mahatma Gandhi Cancer Hospital, Visakhapatnam city. I am going to tell about the motion management in radiotherapy, technical in a clinical perspective. As I am a clinician, I am going to see the clinical aspect, the basics of the motion management in radiotherapy. I am not going to discuss about the more technical details, but how it works, why we need motion management, how we choose motion management, that I will tell you nicely. Why we need motion management? So most of the things in stereotactic body radiotherapy, we need 3 trios. What is ultra high dose radiotherapy, strict immobilization, and motion management. So in ultra high dose radiotherapy, when you are giving ultra high dose radiotherapy, your motion management should be proper so that radiation should be target the tumor, and a strict immobilization is needed. Okay. So Dr. Parvez, Mr. Parvez, can you mute yourself? Yeah. So what are the requirements for the SBIT management? We need micro MLC or cone, planning system, imaging, immobilization, quality assurance accessories, CVCT for the daily imaging and protocols. But most of the important thing is the respiratory motion management system. The respiratory motion management system has to be properly handled to give the high dose radiotherapy. If you see the two diagrams here, one is the inhale position. This is the first diagram is the inhale position, and right side is the exhale position. If you see the inhale position, if take the patient, the person takes the inhalation, more respiration, the diaphragm goes down and anterior posterior diameter increases. If you go for the diaphragm expiration, the diaphragm goes up and the anterior posterior diaphragm decreases. Though very simple two steps for the inspiration and expiration, but in between mid expiration, mid inspiration, end expiration, end expiration, lots of phases are there. Mostly people divide into 10 phases. So we'll discuss again later part. So in inhalation, the lung expands, diaphragm goes downwards, chest expansion is more, and in exhalation or the chest the contracts, diaphragm raises up, and anterior posterior diameter decreases. So which organs are mostly affected by the respiration? Mostly lung, mediastinum, heart, breast, pancreas, liver, kidney, and biliary. Though other organs also moves, we just during the treatment of this all these tumor, we need the motion management system properly. Is lung moves? Yes. As you go from apex to lower, the movement increases. So most of the movement in the apex is less. Even sometimes you don't need a motion management system. In lower, the movement is very much, even 1 to 2 centimeter it happens. 2 centimeter happens from the medial to lateral. In the around the mediastinum, there are hardly 0.5 centimeter movements. But if you go to the lateral, it definitely it increases. Even it is goes to the 1 to 2 centimeter or long moves. So motion management, it may either be super inferior or mediolateral or anterior posterior. Super inferior means up down, mediolateral means left right, anterior posterior the anterior and post. So if you see, there is a small depict about the errors. So any motion management errors happens. It is a mostly random error as well as a systematic error. If a random error happens, the daily treatment goes wrongly. Systematic error happens, though if you not handle the properly the motion management, the regularly that same system, same problem is going on. So getting the perfectionist is more important than handling the motion management. If you see, if suppose in your GTV, CTV, and PTV inside the brain, it hardly any movement happens. But at the same time, if GTV, CTV with respiratory motion like lung and liver, the GTV can move in upward direction, downward direction around 1 to 2 centimeter, even 2.5 centimeter. So we have to, so your area of treatment is more. If you don't handle the motion management properly, the background radiations OR will increase. Sometimes you will miss the GTV during the radiation beam. The orange pill concept. So why we should do know the motion management? If you put motion management and strict motion management, there will be a less PTV. So more slight. So the here the what is orange pill concept? The volume of the orange, and the volume of the pill is almost equal. So slight increase in 0.5 centimeter PTV, the volume is equal to the PTV. So what is the things? What is the best thing I am going to tell you? if you put the proper motion management system, respiratory management system, proper image guidance, you can decrease your PTV, you can decrease your side effects, and you can have a good therapeutic ratio. If you see the SBRT steps, starting from the consultation to the immobilization, positioning, the motion management system plays a role starting from the simulation to the treatment end. So this is the motion management system. You have to be very careful and integrate properly and go for the treatment. If you see through the simulation, if you go for the workflow, the simulation, the motion management, the planning, localization, motion verification, and delivery. From all the steps with motion management system is very important, very meticulously you have to handle about the motion management. So most of the people ask me, shall we go for a simple SBRT system, immobilization system for the motion management, or we will go for the simple backlog system? In our hospital, we did many more cases of SBRT in all the sites. No need of any SBRT board, no need of any SBRT board for the treatment. Simple backlog system, and with hexapod communication, you can do more SBRT in better way. Organs do not follow the statue game. So if you see, even if the patient does not move, the organs will move with respiration, either cardiac movement, liver movement, and spleen movement, kidney movement, everything is there. They don't follow the statue game. So if you everybody is feel better if all things inside the PTV, but PTV should be more smaller comparing to the other with motion management system. It will become even more smaller, and that will be the more beneficial during the treatment. So let's start the proper motion management system. In previous slides, I explained about the why a motion management system is required and how to integrate the motion management in the treatment pathway. If a patient, suppose take an example, in the left side of the lung, if the motion, without motion management, you can see the artifacts, and the area of GTV is more blurred, more irregular, and more dimension in the motion management system without motion management system. But in the right side, if you see the motion management system, if you integrated the motion management system, you can see the tumor delineation is better, no blurring, and dimension also less. So motion management is very important in the day-to-day radiation planning. So is the motion management system is a very easy pathway? No, it is more. The lungs and liver that does not move the only downward, upward, or left or right, or anterior posterior. It moves like a irregular motion pathway. That motion pathway is called hysterical motion. You can see in the animation, you can see that this animation pathway, how the lung move, not directly anterior posterior or not directly anterior superior inferior or medial lateral. It moves like a some irregular pendulous movement known as a hysterical movement. So grossly, we can handle the motion management by ITV generation, abdominal compression, breath holding, gating, and tracking. So these are the 5 methods we can control the motion of the either liver or lungs or any organ. If you see the motion management in a radiation, either you can have a help of the imaging, you can take the fluoroscopy, slow CT, breath hold CT, 4D CT. So these are the handling the motion management by the imaging. You have a breath hold system like a DIBH, like in DIBH, deep inspiratory breath hold, ABC in Electa, like active breath coordinator, patient control, voluntary patient control system, spirometry, audiovisual feedback. These are the helping in the breath hold system. Abdominal compression, you have to compress the abdomen to create a forced swallow breathing. Compression plate or stereotatic body frame will help to give the abdominal compression. Tracking, external tracking means you have to track the tumor pathway or track the motion tumor pathway by external or internal surrogate marker can assist with getting real-time delivery of the treatment. So this is important, and getting is the can be phase based or amplitude based. Your beam will open during the particular phase of the respiration cycle. So so it takes more time. So what are the available menu we have? We have a Electa ABC, that is active breath coordinator breath hold system, Varian real-time positioning management by Varian, CyberKnife synchrony, CyberKnife you can put the fiducial markers, compression, abdominal compression, ITV generation, and voluntary breath hold. So the first system we will see how to generate the ITV. ITV is nothing. So either you can buy internal target volume, you can buy take by fluoroscopy method, 4DC method, 4DCT, low CT, and multiplicity. I will tell you. In 4DCT, uses a technology and localization. A 4DCT uses a new technology that automatically by software it takes the movement of your tumor and movement of the body organs over time. This is a valuable accurately treating the tumors located in the near organs to move, such as those in the chest and abdomen. 4DCT describes various techniques obtaining CT data correlate to the patient respiratory phase motion, so that changes in associated with the respiration. So if you take, if your CT scan is a 4D CT integrated, you can do the prospective get acquisition or retrospective acquisition. What is prospective acquisition? In during the CT scan, you can so in a respiratory cycle. In a respiratory cycle, one inspiration to the one other, another inspiration, or one expiration to another expiration. This is called respiratory cycle. In that respiratory cycle, the all the image data during each cycle, they divide into the images and they acquire the images in the sorting the various images in the image slices in the particular bin. So if it is happening simultaneously with synchronously during CT scan and acquisition, it is called prospective acquisition. Another is called retrospective acquisition.
PPT is not shown.
So we cannot see your PPT.
You are not able to see our PPT?
Yes, sir.
No, I cannot see you.
Okay, now it's okay.
Yeah.
Now we can see.
Please share. Please, yeah, it's okay.
Shall I go ahead? Shall I continue?
Yes, sir. Yes.
Okay. So if
Yes, ma'am.
after the city acquisition, you your software distributes the various phases of the CT scan in various bins. It is called retrospective acquisition. If you might have seen, those people are using Electra system. That is a very good system, Electra symmetry. In the Electra symmetry, there is a prospective acquisition. You can see during it happens in the treatment room, and after taking the simulation procedure, you take the patient into the Electra treatment machine. There is a software called Electra symmetry. If you are not, you can ask your Electra engineers or software people. They will tell you how Electra symmetry works. In Electra symmetry, if you take the symmetry imaging, it will show the images in various. It will acquire the images in various 10 phases, and that will send to the your contouring or planning system. then you can see the how much, and it will give you a video. It can give a video, so you can see these are the various CBCT images. It is a, and it will show you how the tumor moves, and you can your tumor acquisition or tumor target delineation will taken care. Another system, it is called ITV generation by fluoroscopic motion management. If you don't have a system like any motion management system in your department, very crude way of measuring how much tumor moves so that you can give the ITV or PTV by giving. So you just take a fluoroscopy method, either by CR or by any simulator or conventional simulator. You can see if you can mark it as upper marking and lower marking. Accordingly, we can give the margin ITV or PTV. Remember, this is a very way of crude system. Crude, mostly you can find in C-arm or conventional simulator. Multi-phase CT scan. Suppose you don't have any motion management system in your department. So it is in multi-phase CT scan. You ask your patient, take a full respiration and a breath hold. That time you take a CT scan. In a normal respiration, you take another CT scan, and full expiration, take a total exhale and take another respiration, another CT scan. Huge altogether, and that you contour the in a huge image all the GTV in the all three images. You will find that is a ITV generation. So this is also one of the good method to, if you don't have any motion management system. So let's see. This is a full inspiration. This is the GTV. Full expiration. This is the GTV. And full free breathing. You combine all together. That will be your ITV. That will be your the ITV generation with multi-phase CT scan. So sometimes you will find an artifacts in the motion management because and depends upon the slice thickness, pitch, and phases of respiration. So there is a called slow CT. Computer tomography can be operated slowly. Multiple slices taken averaged, and multiple phases of respiration are recorded by slice. Generally available on most computer tomography scanners. So loss of resolution, which may lead to tumor blooding, subsequent increase in observer error in the OR delineation. So if you see, this is the normal fast CT that may be more, it is this is a more accurately you can see. But if you don't have, you ask your CT technician, they will change the pitch of the CT scan, and you can plan for the slow CT, and slightly we can get proper GTV, but the images are more blurred, and it is mostly another crude method of generating ITV. Now, there is what is the intensity projections? There are three intensity projections. One is called maximum intensity projection. Another is minimum intensity projection. What is the average intensity, mean intensity projection? Remember, these intensity projections, you no need to calculate. The software calculates these projections. So what is that? After taking the CT scan or a CBCTs like this, you just ask your software, please generate MIP, please generate MIP, minimum IP, please generate intensity projection. So what is the maximum intensity projections? So if your tumor is in the lung, looks more dense, that is, you have to use the maximum intensity projection. If your lesion is like a liver, there is a lesion in the liver which looks hypodense, then you have to create the minimum intensity projection. That is a more 3D constructed GTV. For the average OIR organs like liver, kidney, spleen, you have to create a called minimum average projection. Average average intensity projection. So hyperdense lesions like long tumors, you have to create a maximum intensity projection for GTV. For for the liver lesions, pancreatic lesion, which looks like a hypodense lesions or black lesions, more you can go for the minimum intensity projections. For OR grunts like liver, kidney, spleen, you have to go with the intensity, average intensity projections. Here 3 beams I am showing you. So this is the 3 animations. You can see first, second and third. First, middle and last. In the first image, if you see, it is a motion inclusive, that is a ITV. This is a ITV. So if you see the ITV, because of the 3 cities they fuse, the motion management happens, taken care, and your GTV, PTV, CTV looks more, PTV looks more. You are treating more area in more normal structures. But throughout the period, beam is on. Another is called gated radiotherapy. That is, if tumor comes to you're inside the PTV, then beam will on. If you see, you can see gated radiotherapy. So beam will on. So either getting means during respiration, either your chest expansion, that is called amplitude, or you chest expansion is, that is amplitude, or particular inspiration in a particular phase of the respiration you target, that is called gated radiotherapy. But if your treatment or beam is tracking the beam, tracking the tumor, and it is all the time beam is on, that is called a beam motion management by tracking. So I will explain again one by one slowly. Let's discuss about the abdominal compression. If you don't have any motion management system in your department, you can use this abdominal compression. What is this abdominal compression? So these are the abdominal compression. You can see by this is called sphygmomanometer or pneumatic compression. Another is called mechanical compression. In this mechanical compression and pneumatic compression, you have to particular pressure, or by pneumatic pressure or particular measurement, you have to compress the abdomen, so that we will create slow respiration. So this is the what do you see here? If you compress the abdominal organ, definitely the motion management will be the respiration will be slow. But if you see, if you are, these are not good for the liver treatment, because it deforms the organ. So it organ deformity or architectural disturbance happens time to time. It will become a random error. So motion management, abdominal compression, it is good if you have a nothing motion management system, but it is not much acceptable in the society, because it causes a deformable organ, and it is not a good system. Best system, one of the I use regularly, that is called breath holding. Holding means patient has to hold breath, stop breath for few minutes by taking after inspiration, either a valved spirometer or by deep breath hold by voluntarily, so that you can reduce the motion artifacts, and dose, you can increase the dose escalation and with free breathing technique. So let's see. This is the motion management system. You patient can see this is how the motion is going, respiration is going on. So this is the spirometry things. Patient take the respiration, inspiration with this spirometry, and this is the nose clip. So how it have this system is available in the active breath coordinator known as Electa ABC. Based on the breath hold, during breath hold treatment, you have to treat, works like a spirometry, needs good lung function. So if patient is not having good lung function, patient cannot hold for the long time, at least 30 seconds, 40 seconds required for the treatment procedure. But if patient cannot handle, we do hold the respiration for a long time, we cannot treat with this technique. So what do you do? We do, this is a spirometry, this is a nose clip. Patient has to take the respiration through this pump. After taking the respiration, there is a valve, it will close, and during the time the chest expansion, and there is almost fixed. So we'll take the beam will on sometimes we have to volume manually you have to switch on the beam. So if suppose a patient is taking respiration like this and he holds the breath, so there will be a plateau here, and during this treatment, during this time the beam will on. During this normal respiration, beam will not on, but when the patient takes breath hold and holds for long particular desired time, then the treatment will the beam will on. So this is how that happens. This patient is asking to take the breath hold. After taking the breath hold, you just manually you have to switch on the beam, and after some time, again the patient relaxes, or whether there is a switch where when he feels very discomfort, then click on the switch, then again it comes to the normal respiration. That time you have to switch off the beam. Sometimes we do the voluntary breath hold system, another crude way of method of. So in a mesh system of the Linux linear oscillator room, we put a bell inside and a mouth, and we will ask the patient to take the breath and hold for a 20 seconds. Then with that time you will beam will on. We can treat a lung tumor, liver tumor, or DIVHN for the breast cancer. And if patient we will allow to patient the switch off, then he can switch off the, or we communicate with us bell, then he will relax and take the normal destination, and we will switch off the beam. So this is called voluntary breath holding using wireless doorbell. So this is about breath holding. Now let's understand about the gating. The gating is you would concentrate on the middle one. Beam is not totally on throughout the period. So when the tumor is inside the PTV, the beam is getting on. You can see the green beam is on when the tumor is right. So how it happens? How it happens? It happens when the patient is in a particular phase of the radiation treatment you can treat, or particular amplitude of the radiation you can treat. Let's see, suppose you are treating with ITV, you have a bigger volume if you treat for ITV. But if you treat in the particular phase, the tumor volume is less comparing the ITV. So it is quite better than normal ITV, and if you treat by gating. So what is the methods of gating system? The delivery of radiation within a specified part of the patient's breathing cycle is known as gating. Either phase based or amplitude based, either it needs some infrared signal spirometry in the external or internal fiducials. Let's see how it works. So a patient takes a respiration. This is normal respiration. So if it is a deep inspiration or deep expiration, that time beam will open. So this is called height or beam amplitude gating. In the lower part of the cycle, cell cycle, respiratory cycle, in the particular phase, deep inspiration, we will switch on the beam. This is called phase gating, respiratory gating cycle, amplitude gating or respiratory gating. So how it happens? We take a CT scan and divides in all the image slices into various cycles. It is you no need to worry how you arrange all these things. It is arranged by software system, and you have to see the contour in the particular phase, and you treat in that particular phase. This is known as a gating. So how it happens? Mostly it found in the variant gating synchronization. This is the infrared camera. This is the infrared marker. So if patient takes inspiration, chest expansion happens, there is a synchronization between the camera and the marker and the beam. So treatment will happen if patient who holds the breath or during treatment. If patient relaxes, there is no coordination between the infrared camera and infrared marker. So the beam automatically switch off. This is called RPM, real-time positioning management system by Varian. You can see again, this is the infrared marker, this is the infrared camera and the beam. So this all three synchronization happens once or in a single, then it beam will open. Otherwise, if it is away from this tracking, away from the contact, then again it will not, the beam will not on. Another system is called pressure sensor gating. These are the available in the Siemens Anzai respiratory gating system. This Siemens Anzai gating systems are not so popular, and because before the actual development by Varian and Electa, they developed a belt and or pressure system. They put in the chest cycle, and during the again same, if there is a pressure change, then the beam will open. Otherwise, beam will on, or pressure decreases, then beam will switch off. That is called Siemens Anzai respiratory gating system. Same system, another is called Philips bellows gating system. So again, same thing, some belt or pressurization, it will wrap around the patient's abdomen or chest, and the changing in the pressure, it will sensitize the beam on, and like that it happens. But these people things are not so popular. Another is called camera based gating. It is more popular nowadays. That is called Vision RT, SGRT, Gate RT. So here no motion management system happens. It is a 3D. Lots of pixel cameras will be there. It will change according to the reconstruction of the image, and multiple cameras it will take. So this is called surface guide. Another thing is a catalyst surface guided RT. So these are called Vision RT, surface guided. There are many optical systems are coming nowadays. So here surface guided radiotherapy, immobilization and motion management, no external surrogate marker, 3D camera based, auto beam control, auto couch correction, applicable to any form of radiotherapy, no extra radiation dose. Catalyst captures the complete body surface. The non-rigid registration algorithm compares the current practice and posture and the previously recorded reference setup is in real time. So this is a system where it is based on the camera. Then comes to the tracking system. You concentrate on the last image or third image. If you see more throughout the treatment period, beam is on. So how beam will on? They will put some marker by invasive method through CT scan. They will put some fiduciary marker inside the CT scan, and that will tracked by your infrared camera or and beam continuously switch on. So if there is a slight error in the movement, it will show the real-time positioning. So motion management tracking, real-time delivery, radiation simultaneous tracking, increased imaging, but it is more dose by fluoroscopy. Significant reduced margin required. You can see there is no much margin comparing to the gate rate and the ITV. No beam up during treatment. Whole the time the beam is on. Mostly gold seeds or VC coil they insert inside the tumor, and mostly available in the CyberKnife and Exactra system. So there are two systems are available in the tumor tracking. Exactly the Exactrack system by Vero and CyberKnife. What happens? There is a linear accelerator. There is optical markers. There is a tumor landmark. They put the fiduciary. So there will be a correlation between the optical marker, Linac beam, and the surrogate markers like that fiduciary markers. So continuous the Linac will that stationary, the beam will not stationary, though it will move according to the tumor path. This is called tracking. So you can see the tumor fiduciary markers they put inside the by through needle. And if you can see infrared tracking system, external marker and beam source. So here you can see X-ray based tracking. There is no CT scan in the CyberKnife system, as you know. This is X-ray based, fiduciary based, and the roof, there is a roof mounted X-ray. Monitoring throughout the entire team, precise image fusion, immediate alert if there is a slightly discrepancy, and automatic error correction. So another system is called exacta system. Same thing, and the X-ray is a tube is in the bottom floor. Here X-ray is on the roof. There is a new thing is called a synchrony, not new. Now it is they integrated in tomotherapy and as well as the cyberknife by so you can see the this is the external markers again. The how it works. Direct remote tracking allows for a complete non-invasive fiducial. Here no fiducial is required. The custom designed synchrony based tracking marks allow to simplified patient setup, marker placement, especially in the multifraction treatments. Patient breathe normally in complete comfort throughout the treatment delivery. The synchrony system tracks the respiration real time. Though you can see this is a best. This is the best. This is the tracking by your computer and beam. So with the synchrony system, physicians no longer have to add significant planning margins. So how it is synchrony solves it? You have to put external marker, that is a external marker, though the best is to wear by the patient. Before treatment, the imaging fiducial marker placed in the near the side of the rest of the exact tumor location. There is a called external marker internal tracking. There will be a correlation model which develops the internal tumor motion, the software generated, and this is a real tumor tracking management happens with the cyberknife synchrony system. In summary, external signal through getting either amplitude based or phase based, internal signal by tracking. Breath hold is also type of amplitude based getting. In the various motion system, you can see the variant RPM getting and breath hold, electroactive system, accurate cyberknife, abdominal compression, electra body frame, SIPCO body frame, medical intelligence by body fix, and other systems. So let's see three systems let's compare. In a breath hold system, it is very accurate. Disadvantage is that patient, if the not good respiratory function, we cannot use it. Patient has to hold the breath by the spirometry and treat, mostly available in the electa. Respiratory getting, variant RPM system, compatible with the patient with poor lung function, no need to the breath hold, requires regular reproducible breathing. Beam delivery occurs when the tumor in the particular getting amplitude or a particular phase. Free breathing, and you are generating a ITV. The target volume will be more. You take a normal respiration, deep inspiration, deep expiration, combine all, you may generate a GTV, that is increased volume and of tissue irradiated. So there is a good article, you can go through it by Barbara Bushels. You can go, and it has given the all methods, advantages, disadvantages, what are the general description, what I have explained earlier, all these things. This good article for the learners, they can understand. So I have taken from the cyberknife systems. You can see a so it is not a marketing or something, just it is a easy understanding how it happens. Let you. So you can see in the left where is no motion management with compression. So sometimes it is a tumor is out and tumor is in. So if you can see here, if there is a generate ITV, your volume will be more, and the tumor, the area of opening is more, so more OR doses. Oh, yeah. Just there is a technical error. Okay.
We cannot see your PowerPoint presentation.
Yes, 2 minutes. There is some technical error. Again I'm presenting. Just 2 minutes.
Okay. Okay. Yeah, now it's okay.
Okay. So if you see that this is called breath hold, you have to compress the patient with breath hold. This is a spirometry. So this is called getting. If you see during the particular phase of the patient during the treatment, so this is getting. So as this is for educational purpose, not for any marketing purpose, but I liked that video to explain the people how to. So which motion management system is better? So this is the thing. Answer lies in your department. What your management, what is your company gives, that is better. So either you have to adopt your what management is giving to you, that has to you understand. So the art of learning, how to the managing management, how to what to ask. Either I will ask for the ABC, I will ask for the RPM, I will ask for the synchrony. You have to get training about the managing the management. Thank you very much. These are my other classes, stereotaxy classes I can take by the SBRT for all sites and SR for all sites, and target delineation classes for the all sites, and radiology classes either came from the brain, skull, neck, thorax. If I take 8-hour classes. Apart from that, neuro-oncology classes starting from the SRS to the conventional treatment. These are my social medias educational series. We have you can follow me on these things. And thank you very much. Anything you can connect my email and mobile number. If you want to download the PPT, and we have I called app is called Onco Education app. You can download this and you can download the presentation. Thank you very much.
Thank you very much. Shall I call you Dr. Patro or Dr. Kanhu?
Yes, ma'am.
All right, okay. Thank you very much, Dr. Kanhu, for such a comprehensive and insightful presentation. You have highlighted the clinical challenges of motion management. You also shared our practical strategies from your experience, and also emphasized the importance of the precision and accessibility in radiotherapy. So I can see in the chat box, yeah, Dr. Kanhu, we received many thoughtful questions for you in the chat box. Yeah, you can scroll up. We have so many questions there. To keep on schedule, we will now to move to our panel discussion. But if Dr. Kanhu have some times, maybe you can respond to some of those questions directly in the chat. We will try also to address these remaining question later during the Q&A sessions at the end of the program. Is that okay, Dr. Kanhu?
Dr. Rosie, I will
Yes.
share the question. Okay, I will share the question. So you can first.
Yeah, but
Discuss.
shall we continue to panelists first, and then we open
Yeah,
the
sure.
discussion
Yeah,
at the end? Yeah,
Yeah,
okay.
you continue
So
the
that because we
discussion
are
first.
running out of time because we begin a little bit late. So if Dr. Kanhu have some times, you can refer in a chat. But the remaining we can answer, we can keep during the Q&A session. Is that okay?
Yes, yes.
Okay, thank you very much. Okay, the audience, before we start to our panel, and we have a very distinguished, very experienced panels. I would like to have some little bit of engagement here with you again. If you see in my in the chat box, I have a question on if you have any face challenge with patient motion during radiotherapy, you can tick right there in the chat. So give some ideas to the panel about these challenges that probably you can share. What are the challenges you face for patient motion during the radiotherapy? Moving on, now let's turn turn to our distinguished panel. We will keep this discussion concise. We have only 20 minutes, yeah? So I will invite our panelists to respond. Probably we can go for 1 or 2 questions. All right, we will have to welcome Prof. Alaei first from USA. Hi, Prof. Alaei.
Good evening to you all. It was a very comprehensive presentation by Dr. Kanhu in a very short amount of time. I'm impressed by covered everything, basically. And I'll be monitoring the questions on the side. And is there any particular question you want me to answer or in general?
Yeah, basically, we have a general to start with, all right? So I read your research, most of your research actually focus on dosimetry and treatment planning. And in your view, how will adaptive radiotherapy, when we talk about adaptive radiotherapy, reshape the motion management and those accuracy in these coming years?
Sure. Adaptive therapy is we all know is a wave of the future, or maybe current. Not everybody does it. I mean, we don't do it ourselves that often. But the motion management would assist with the adaptive therapy because we have to manage the motion first and foremost before we can adapt to the tumor and create a plan for that day, let's say. And that is being done right now mostly with the MR Linac at the moment. But again, we are limited in how we can manage the intrafraction motion, as you know, because not everybody has gating or tumor tracking, which is a technology that most people don't have access to. So interfraction we can manage, and the adaptation we do these days is basically on interfraction right now, day-to-day variation. So we are limited in what we do or we can do on the intrafraction, except if you have a tracking or one of those new devices or tools that is not accessible to everybody. So yeah, we will improve the dosimetry for sure. But we have some ways to go still on that.
All right, thank you. So, Prof. Elhaddad, if we can, I mean, like from your perspective, when we mentioned by Prof. Alaei that there's about adaptive radiotherapy and in motion management. From your point of view in clinical side, how do you see these advances of our technique, what we have, translating into the patient outcomes?
I think this is a bit of a tricky question because when you invest, you would expect this to be reflected on the patient lifespan and kind of like they live longer, overall survival advantage, progression-free survival advantage, and maybe it is not, or we are not fortunate yet to prove this in all tumor sites. But I think like in lung cancer, we definitely made a very big change in terms of the survival and comparison between surgery or SABR in lung cancer and surgery, for example. So the advances happened in certain tumor sites definitely proved to have an impact on the patient survival, but not all tumor sites will show that. And I mean, as a third world country, it's a bit tricky to put all your investments in one packet, and how much you put here and how much you put there, and how much the patient or how many patients will have access to the high technology. So it's a bit tricky. But in general, I would say we definitely reduce toxicities for most of the tumor sites. There is no doubt about it, using the high techniques. We improved the survival and tumor control for many tumor sites. There is no doubt about it. But the problem is usually a financial issue, basically. I personally have a lot of questions in this really interesting topics, and I would be interested from the panelists and from Dr. Kao if he can also help me with that. I mean, for technical points of view, when you use the cone beam CT, can you change the amount of radiation going inside the patient? I mean, when you match for soft tissue, do you use a high dose in cone beam scan, and when you match for bone, do you use for low dose scans, or will it make, can you control that and you make this in a routine daily treatment? There is a few other questions, but I don't want to take most of the time. But I thought this is one of the topics that highlighting it would make kind of be interest for the audience.
Rosie, may I address that question? That has been my research for last 10, 15 years. So the answer is yes, you can do that. We are not doing it. Some are doing it, but there is a movement in optimizing the IGRT, the cone beam CT that we used. Actually, there's an ICRP report. I'm not part of it, but ICRP TG 116, which should be published soon. It addresses that question. And there's more work to be done. So yes, it can be done. We've done it, and we are trying to make it more, I guess, routine in the US. There is more of that being done in the UK and Europe in general than US, frankly. But yeah, we are working on that one for sure. And we can chat offline if you need to.
Yeah, that's interesting to know. Thank you.
May I interfere here as well? Because yeah, in UK now we just released, there's a new report just released this year. It's dealing with this kind of optimizing the CBCT dosage to the patients. And yeah, there is actually Varian and Electa both have a multiple protocols, many protocols where you can change between which protocol to use for imaging. But actually this needs some kind of diagnostic physicists to do some work out on how changing the energies and dosage, and then what the effect of this in the image quality. But yes, now we have here in UK, it's like kind of now legally wise we need to optimize the KV dosage to the patient.
And you optimize it, you calculate it,
Yeah.
and then you put it within the sum total dose.
Yes, now we are we are working now on how to to minimize the dose as low as we can, and we're now in collecting this data now, and we're gonna to put it into the received dose or the dose delivered to the patient at a final report, especially with SPRTs and this kind of high techniques. We use CBCT as extensively. You can make for one patient like about 3-4 for one plan, 3-4 CBCTs to get it per fraction. So which is quite maybe as high diagnostic dose.
Thank you.
Thank you, Dr. Yunus. You shared some of your investment in your facilities you have there. So I've read that you work with CyberKnife, Electa Variant, and Blu-ray system. So from your experience in UK, which technologies actually have shown the greatest real-world benefit for motion management?
It's a good, it's a very complex question to answer actually, because every machine has its own benefits and its own drawbacks actually, to be honest. However, the new improvement in the imaging reconstruction algorithms, which is used for the CBCT now, they are in Electa and vary, and they are boosting their the imaging algorithms now to get a better image quality which will help hopefully in the adaptive radiotherapy. So that means we can get a good enough images. CyberKnife has a good motion management little bit because of this kind of tracking, but there is still some limitation with CyberKnife, which is you don't have this 3D imaging. You just tracking the solid items or objects. So you need like kind of fiducial to be there or something like that. So which is sometimes it's it's invasive, quite invasive procedure need to be done to the patient. And yeah, and it's still KV image. It's not like you can't see the all organ at risk around the tumor. You just rely on what you have, what you can see. So this is one of the drawbacks. If we're moving forward to the Vuray, or let's say MR-Linac is you can get a very nice imaging. It's very you can see it's well it's MR quality. Either Vuray or Elekta both have a good quality MRI images, and still there is some limitations with it for some patients actually, but yeah, it's still the MR-Linac represents the best image you can use, and it represents the best motion management tool you can use it, because you can see the tumor itself, you can see the organ at risk itself at the same time, which gives you a good observation to what you are treating, where the dose is going on. Yeah, so to be honest, it's hard to answer. You can't have a one machine to give the whole solutions for everything. Yeah, so but to be more practical, as practicality and financial wise and all stuff, the Linac based now is a good, it introduces a good motion management actually. For example, for one of the Linac vendors now, you can get like a kind of, it's not tracking, but it's more getting triggered imaging, which you can see. It's the same as CyberKnife, but it's not tracking. You can see if you can see the internal motions during the treatment interfraction movement. So you can see it and deliver those based on that. So yeah, so this is one of the things. And as I said, the new imaging quality for the Linux is very, very good, and they are posting it very nice, and so you can see a better internal motions and all of stuff.
So our participants actually comes from various part of the world. You can see that we have Ethiopia, me myself from Malaysia. You can see from Egypt, from other country also. So when we talk about MR-Linac, for us in Malaysia, it's a luxury. We don't have one.
It's luxury everywhere, actually.
And for some, I mean, like I think that from my personal opinion, as we know, everybody knows that there's an organ motion. As long as you can track it, you can correct it. It's probably, I mean, like with whatever tools, the best tools that we can provide, that's the best thing, I mean, for physicists, for oncologists also to deal with it, right? So whatever we have. So we can see there's some gaps. We have like imaging, we have for dosimetry, for planning, things like that. So Prof. Alaei, from your experience, I mean, like from your thoughts, are we ready for our physicists to fill up these gaps with when we do the tracking of motion or dealing with the motion management? So these gaps of transition from the imaging to the treatment couch. So our generation of physicists, especially when we talk about physicists or oncologists itself, are we ready for these gaps?
I didn't quite understand about the gap going from what we do now, what we can do or will do. the future. It is a challenge. I mean, you mentioned the MR Linac is a luxury. I mean, Malaysia, even in the US, there aren't that many of them. MR Linac costs 3 times a Linac, so I mean, not everybody can afford that. So yeah, and again, I think the issue was brought up about the finances and all that. Those are all valid, even in the US. It is valid in the US too, financing. Yeah, we are. I think the challenge that we have is manufacturers come with all these very, I call it the fancy tools or techniques that we can utilize. And the physicist needs to be aware of the limitations of those tools. You have to be careful when you get something is not we call it plug and play. You need to verify that. You need to make sure that the challenges ahead, the limitations of that, you cannot use surface imaging for everything. We do surface imaging ourselves for the IBH. We do not use it for internal organs. We do not use it for lung or abdomen because, again, the surface correlation of the surface movement and the internal organ is not a one-to-one. It's not easy to navigate or figure out. So again, you have to be careful when you have these new tools that, again, I think Dr. Elhaddad mentioned that the manager buys for you. You have to be careful, and when you try to implement them, make sure that you know what you are implementing and what limitations are and what treatments you can use it for. So it is challenging. It needs education, training, and again, doing your due diligence before employing any tools that you have.
Yeah, thank you very much. I think what we're doing now, by having this webinar also, we try to make the gaps closer, right? Okay, I can see that Shata Nazal, you raise your hands. Probably you have some question to ask our panelists.
Yeah.
Please.
Excuse me. Yeah, my question is that in image-guided radiotherapy, we have a time delay between the image taking or the detecting and constructing, and so is this? I mean, do you consider that when you do the PTV, when you control the PTV and get the margin? And so the question is, are these techniques really important in each treatment, or it's just for some kind of treatments like SBRT or SRS?
All right, I open maybe Dr. Yunus or Prof. Alaei.
Yeah. Okay, so the first thing, when we do the PTV margins, we taken into account a lot of things. It's not only so one of them is the image matching accuracy. There is a known equation. I can share it with the paper with you, which is how to calculate the variations between like the image fusion or stuff between different people and what's happened between different radiographers during the course and all of the systemic error and random errors. So it's called Van Heck equation. It's very famous tool. You can use it, and there's like a machine itself, how your machine eye center is, and you need to so there is something taken into account when you are adding your PTVs. For the mobile lesions, like lung lesions, if you are talking about, take the image only for 4D, for 3D, free breathing, 3D only for planning, you don't take into account 4D or something like that. So you have the margin should be considering this. So you have like larger margins. And that's why I think Dr. Kanhu shared in the beginning of the presentation something about if you are like the 4D, how we will implement the BTV or the ITV, and if you are thinking like BTV from the free breathing, it should be like large, it could be bigger than that. So this is kind of how the PTVs are created, depends on how you use your motion management. the idea of difference between the IGRT, the time between IGRT and the team delivery, it depends actually where are you, what the techniques are you using, and what's the, I mean, for the vision, for the motion management, and what is the PTV area or something like that. So if you are talking about something in the lung and you're treating in 4D CT and something ITV, so that means you are already taking into consideration all phases of breathing. So it's regardless whenever the motion, it's already included in the ITV. And then you added the PTV on top of that. So this is how these PTVs are normally is calculated for everything, and that's the answer for that part of the question one. And for the which techniques you can use the motion management, to be honest, yeah, you can use it for any technique. It depends on, yeah, what you need. So you can, okay, for SBRT, that's fine, but you're also treating radical lungs, not SBRT, it's like VMAT or 3D or whatever. So it's better to have 4D CT, for example, or treating with breath hold. Depends on what techniques you prefer in at your center and what's the tools you have. So because it's actually to be, yeah, it makes it makes a lot of change in the irradiated volume. That if to be honest, if you are using the proper motion management, otherwise you need to increase your PTV to be sure that you are covering everything, and that means you are irradiating more healthy tissues. So that's my, yeah, yeah, I would say you need motion management for any technique once as far as you are treating a patient.
All
And
right,
if
thank you, Dr. Eunice. Okay, thank you, Shata, for your questions. So we have collected a few questions also from chat box. I think the earlier question is for Dr. Prof. Kanhu. Prof. Kanhu is still with us? Or maybe other panelists would like to share also. May I know if Prof. Kanhu is still with us or not? Hi, Prof.
Hello, Professor Kanhu, can you hear you? Okay, maybe we go to
Right, we
our
can read for the first question. In phase gating or amplitude gating, we use optical surface monitor which track PTV indirectly by tracking surface. Is it same like tracking surface, or is there any difference in gating technique for motion management? So basically looking at the differences between the optical surface monitor. I try to understand the questions. Phase gating and or amplitude gating. The difference between these two gating approach. I think this relates to Dr. Kanhu presentation where we have the beam on, beam off
yeah, I can,
gatings. Yeah.
yeah, I can share something here actually, because there is, yeah, phase gating is quite different from the tracking. The tracking is your beam is following the tumor wherever it is, so it moves as, yeah, the same position as the tumor. So that's follows, and that's the only system can do that is now is the CyberKnife.
CyberKnife.
Okay. Yeah. For the gate phase gating, that means you did your plan at certain phase. So from the 4D CT, you take 4D CT and you take, like, let's say you are taking you found that the best or the longest phase is like 30% external phase, for example. So you did your planning at that position or whatever. So, and then when the patient is treated under treatment, so you try to get the same phase. Once you are at the same phase, you still it will deliver the beam. Once the patient is outside this phase, the beam will be stopped. So this is the idea of phase gating. It's, yeah, it's a kind of, if if we can mimic, it's like a kind of breath hold, but the patient doesn't do breath hold. So that's the same. This is simple way. So once it's in that phase, beam on, outside the phase, beam off. So that's
okay. We move to the second question. Probably Prof. Elhaddad can help us to probably share your experience in your center. What is the optimum size of tumor when you consider SBRT using motion management technique?
I think we are talking about lung mainly, looks like. I mean, most of the lecture was directed towards the lung. So I think it's very important to put into consideration is not just the size, but the toxicity or what will happen after the treatment. I think most of the data would be coming from tumor between less than 5 and maximum of 7, but I wouldn't go beyond that. But we have to put into consideration that the larger the tumor size, the higher the risk for metastasis. So you may not succeed to control the disease properly. So proper selection with the patient with small tumor size, negative mediastinum,
A bit breaking, Prof. Elhaddad.
and then you push your guess. I think this will be, sorry?
A little bit breaking
Did you say
just
something?
now. Now okay, now getting back. Yeah.
I'm sorry. So
It's okay.
can you hear me properly?
Yeah, now okay, Please proceed.
Sorry for that. So what I was saying is choosing the proper patient or the selection of your patient with a small tumor size, negative mediastinal node will reach with your patient a best outcome. So although we can technically treat up to 5 or up to 7 centimeter tumor, but control rate wise, a survival advantage wise, may not be the best, similar to or the same as another patient with 1 centimeter or 2 centimeter sized tumor. So I would say in our center, we don't go beyond the 6 centimeters maximum, but I know that other centers maybe go up to 8 centimeter by increasing the number of fractions, reducing the tumor dose, and take into consideration the toxicity for normal organs. So it's different protocols for different tumor sites or for different centers, I would say. Sorry.
Yeah, thank you. All right, probably we go for last questions. Maybe Prof. Alaei can help me to answer the final third one. What if patient can't hold breath for simulations or at time of the treatment? Rather than RPM, what we can do for better treatment? Prof. Alaei, can you help us to answer this?
Sure, and I mean, not all the patients can hold their breath or have regular breathing cycles. So here it says mentions RPM, but let's talk about deep inspiration breath hold. If the patient cannot hold the breath, let's say 30 seconds, we just don't do it. Because if the patient cannot do it and does it one day and doesn't do it next day, we are not doing any good for the patient treatment. So we'll try to do a free breathing and do our best in getting a plan that is the most appropriate. So in our practice, if the patient cannot hold the breath, just won't use it.
I think for this type of patient, even body compression also doesn't help much, right?
Well, actually, body compression does. We actually employ that. Frankly, we actually employ compression for all our long SBRTs, and it does minimize the motion. Yes, but then again, that's a good answer. Actually, I should have thought of that one. You answered it for me. But yeah, so yeah, body compression works. I was thinking of breast that came up. But for long, yes, compression is probably the best. Frankly, is the simplest, right? Probably the cheapest too. So yeah, I would do that if they can do it.
All right. Okay. I think we are about time. I hope that the committee will probably get the answer from Dr. Kanhu or our panelists. But before we end our session, I would like to hear some like wrap up, about 1 minute from the panelists about motion management. Yeah, probably that sorry, can probably that before we move to the end of, before we end our session, I would like to invite probably Prof. Alaei to start with. Probably you can share a closing thought, perhaps a key takeaway or piece of advice for this, for the future of motion management. Maybe about 1 minute, please, Prof. Alaei.
Of course, yes. Thank you. Thank you for the invitation, by the way. So motion management, it is a complex issue. It's not a simple, I mean, even RPM probably manages the motion only in one direction, up and down, right? Keep in mind, motion management is in all directions. Intrafraction is in all directions. Interfraction, again, is rotation and translation, both of them. And if we want to do it, employ that for a patient, we need to make sure that we have the tools and we know the know-how to do it. If we cannot do it, if we are in doubt, we shouldn't do it. We should just put a bigger margin, this is my opinion, bigger margin and treat the patient like we've done for the last 50, 60 years. Again, motion management helps with the reduction of the margins, of course, but if it cannot be done, let's not do it. And if we do it, know the limitations of that. I mentioned that before. And that's the role of the physicist mostly, to know when and how to use any device that comes their way. You're mute, Rosie.
Oh, sorry. Thank you very much, Prof. Alaei. And then we move to you, Prof. Elhaddad. Maybe you can have some say from clinical perspective.
I think motion management will stay, and I think there is a lot of things still to come and see. I'm expecting that we will see the tumor moving live, and we'll start to treat and and see the tumor reduction live. I think things will improve in the next 5-10 years a lot, and I would say still there is a lot of research to be done, whether on the physics side or clinical side. I encourage all my colleagues to start working on it in their department. And the artificial intelligence, I think will play a big role here, and in terms of interpretation of the images, changes, those calculations. There will be a lot of automation happening, and I think the next few years we'll see a lot of changes. So that's what I would say about motion management. So it's a really interesting topic. So thank you for choosing it.
Thank you very much. Yeah, it's another topic about AI actually in organ management. So probably the 20 minutes of discussion is not enough for us to wrap up everything. I know Dr. Yunus also has so many things to share, but probably 1 minute you want to wrap up some notes for our audience?
My take home lesson actually, motion management is very crucial thing we need to think about, and we need to use all our facilities, and we can improve what facilities is more appropriate for our patients, and we need to push hard to use it. Actually, to be honest, there is a lot of different modalities you can use it, even fixation, the patient himself, and your machine. So you have to understand the whole workflow and the whole parts, and then you can start implementing. One quick case, very interesting case we had. It's related to the last question. We have a patient having liver mets, need to treat with SBRT. The patient can't breath hold. The patient can't do 4D CT. So in that case, what shall we do? It was very interesting patient, and it's ended up that we moved to the triggered imaging technique. So the patient free breathing, and we insert like a body shield into the patient, marker into the close to the the lesion, and then use triggered imaging. So we managed to use like a good small enough BTB margin, and we managed to treat the patient as it is. So this kind of, you have to understand exactly what's your machine have, what your tools you can use, and what different, but still the motion management is a crucial topic. Actually, we should focus on it. Thank you.
Thank you, Dr. Yunus. I think your thoughts, I mean, like your notes align with Prof. Alaei also. Know your tools, and then you have the tools, but you need to know how to handle the tools appropriately. All right, I think we come to end our today's session. All right, we summarize a few key takeaways. Just to share with you, like I started doing motion management for my studies, for my doctorate 20 years ago. So my end product of my thesis is margin of the day. So after 20 years, Alhamdulillah, I'm still here, that this motion management still valid. We're still working on it. And I do believe that more and more research or more improvement that can be done. So motion management actually both technical and clinical got challenged and requires close collaboration. We have oncologists and physicists, right? So we talk about advances also, advances in adaptive radiotherapy, image guidance, or getting technologies, making a treatment more precise, and we go for patient-centered. And we love to see here a global collaboration. We have so many physicists from all over the world gather and do the knowledge sharing, which is essential for overcoming the barriers and also spreading the best practice. Okay, all right. On behalf of organizing, Abu Kausar, you want to report?
Professor
All right.
Kanhu has joined us. Just I would request
Okay.
Professor Kanhu to share his thought in on minutes, please.
All
Then
right.
we'll wrap
Okay,
up
Prof.
our
Kanhu,
program.
sorry.
Yeah. Thank you for the invitation. I am very glad to attend your session, and very nice. All faces from across the world they joined. Hope you liked my presentation, and hope I met your expectations. And the motion management system, only the problem is you have Electa ABC, Varian RPM, and synchrony with Cyberknife. So it is they're like interchanges. You cannot use RPM in Electa. Now you cannot use ABC in Varian, and you cannot use synchrony in other two systems. So these are the main drawbacks. And so which is better? So it is not the better what we get, that is better. What your management is giving, and you have to adapt to that thing. That is my final word.
So thank you all for our insightful presentation, and thank you to our experts for their remarkable expression to this presentation topics on motion management in radiotherapy. So I'd like to thank you all for joining us, and hopefully we will work together for in this chapter, even like a limited constant that we are practicing these areas. I think the problem are the same throughout this region. It could Asia, Africa. So hopefully we'll overcome, and we can work together for the betterment of our patient, for our treatment. So thank you to our all participants, all panel of experts, our moderator, and of course our speaker for giving your precious time to us. So see you soon, and thank you all.